All right, friends, thanks so much for joining at your lunchtime today, last day of January. And again, welcome to all our hospitals. Welcome to the MUHS University. I've been told all systems go from all their ends. You guys can listen to the presentation, see the screen. So we'll begin the session today. So our topic for today was blood transfusion and clinical and regulatory review. And like all the participants who've seen our show before, there's a whole issue on clinical regulatory requirements that we talk about, documentation, and so we'll show you on why we had to choose this topic. What is the current guidelines on when to transfuse? How much can the body tolerate? And then talk about some economics on blood transfusion. Like always, a disclaimer, when we use CPT, that belongs to the American Medical Association. Interqual is a product of McKesson. When we use CMS screenshots, we'll be providing links to that site, so we don't download any of their products. This is one slide that we've always begun with, and this is the spectrum of auditors. And the reason this is traffic color coded is in the severity on how they can affect hospitals and bottom line. So the bottom two, which are the QIOs and the CERTs, they help us. They help the organization. And when we move on to the next slide, I talk about routine compliance is what these two organizations try and enforce. When we go into the middle zone with the MACs, MICs, and RACs, this is where compliance oversight happens. And when we're in the top three, the reason they're red is because these are legal oversight organizations. So the Department of Justice, OIG, and the ZPIC. Now, insurance companies are also sending these notice of improper payments and recoupment, and thus they are doing their own internal auditing. Now, not only do they do DRGs for auditing, but what they're looking at is the entire stay of this patient, not only in the hospital, but when office visits are being done, when procedures are being done. Now, everyone is aware of the MACRA and MIPS guidelines and the payment adjustments that are going to happen starting 2018 onwards. So what is happening now is the base collection year, and what they're looking at is quality resource use, clinical practice improvement activities, and then meaningful use. And then as time goes on, there will be adjustments of either positive or negative 4 to 9%. Why this is important is what we teach in our topics of disease-specific documentation actually encompasses a lot of the quality improvement activities that are required in the next 5 to 7 years. So we know about the MACRA, the MIPS. There's some next generation ACOs coming, comprehensive primary care plus programs, chronic care management. So these are all they come under the value-based heading of new CMS incentives. And documentation on the medical record pretty much trumps on whatever is going to happen in the next few years. One question that we've always talked about is, what do auditors look for? And so what they're looking is, are these services reasonable and medically necessary? And in this particular presentation, the concept of blood transfusion. When is blood transfusion reasonable? When is it necessary? And we'll talk about some evidence-based studies. Now, do these services meet professionally recognized standards of care? And so when you're transfusing someone at hemoglobin of 10 or 11, that is not meeting a standard of care. Now, the third question they look at is, do the services, can they be safely delivered in another setting? So, simply admitting someone for a blood transfusion, unless there is some good positive documentation, may not satisfy this question that they're looking at. Now, CMS had introduced a number of things that auditors look for, and this is a busy slide. I'm not going to read this. People who have access to the LMS, you can pause at the PowerPoint, you can download it on your devices, and then read on what sort of issues are being looked at. So this is slide 1 of some of the issues. This is slide 2 of some of the issues. All of it pretty much revolves around documentation. So if there is a late entry, if there's a delay in care, if there's unnecessary care, you need to justify that with the documentation that you're providing the auditor to look at. So this is what in this slide. It's an interactive slide for Aerolib. We've done more than 5,000 reviews, and when we see a hemoglobin and blood transfusion audit, we roll back into what was the documentation, what's the audit risk. So let's divide our slide into three columns: hemoglobin less than 7, between 7 and 9, and greater than 9. And this is our x-axis. We'll have two y-axes, one where the hemoglobin is just less than 7 or at least at 7, and one that's at 9. Positive documentation, and as we go through the slides, we'll tell you what positive documentation is. That is on the positive y-axis. Negative documentation, or technically no documentation, is on our negative y-axis. So let's look at our audit risks. Now we've seen if you have a hemoglobin of 9 and you're transfusing blood, irrespective of what sort of documentation you have, there is an audit risk. Just because the evidence-based guidelines for transfusion above 9 are lacking. Now, if you transfuse above 9 and you have no or negative documentation, that is a bold red audit there. That's a huge red flag. Between 7 and 9 with good positive documentation, it's orange. You may be audited, but again, when they review the chart and look at your notes and a specialist note, it falls in the medium zone. Between 7 and 9 and no documentation, again, huge red flag. Now it's the hemoglobin less than 7. That's where your audit risk is low, even if you have no or negative documentation. This does not justify that you shouldn't have negative documentation, but it just means that less than 7 is what is standard of care for accepting blood transfusion. And like I said, as we go forward, we'll talk about what this positive documentation is. So our goal here is going to be discussing some background, talking about anemia tolerance, hemodilution studies, risk of blood transfusion, what's the cost, where does ICD-10 come in, and the last few slides on what the payment updates from CMS has been regarding blood transfusion. Now I want to start with this iconic Indian movie released many years ago. Here is their mother who is lying and needs blood transfusion, and these are three very famous Indian actors. All of them are lying concurrently, and this blood is going into this zone here. So this is a huge myth. This is not how blood transfusion works. However, for many countries, some people had the perception, and even when they come into the hospital and are told their relative needs blood transfusion, they'll say, just take it out from me and put it in my relative. Doesn't work that way. Blood transfusion has a huge life cycle, right from donor registration, donor screening, phlebotomy processes, grouping and screening, blood processing, blood component request, crossing matching, and then issues of blood component for transfusion, finally to transfusion, and then blood disposal. So the whole process is a combination of recipient and donor matching, and it's a complete science for blood transfusion management. I'd encourage people on the LMS to stop at those slides and look at those flow charts. I think for the purpose of today, we're going to talk about what's the right hemoglobin level for blood transfusion, and evidence is weak for any number. So 10/30 is hemoglobin of 10 and hematocrit of 30. No one knows what the right number is, but the bottom line is blood is scarce. Now 85 million units of blood is transfused every year. Of that, 15 million are used in USA itself. So it just goes to show that a lot of the restrictive blood transfusion practices are being done in other countries. However, the number is lax in US. Now, BT or blood transfusion can have complications. We'll talk about those, and blood transfusion is costly. And as the presentation moves forward, we'll show you what the cost is. Now, the above link takes you to the Medicare.gov site for coverage for blood transfusion. And as you can see, whether you have Part A or Part B, Medicare does cover the first 3 units of blood you get in a calendar year. There's some nuances to this. This is the site that's meant for information to the public. When you look at the provider site, it talks more into when can you give it. And in the next few slides, there's an NCD for blood transfusion. We'll be talking about that also. But there is a small note in both Part A and Part B where Medicare does expect people receiving blood to have the blood donated or have blood donated by the beneficiary or someone else. So again, they do promote it. It's something that a lot of people don't know about. Now, what's the most common blood type? And all the clinicians in the room know, we know the AB and AB, A, comma, B and AB and O, positive and negative blood groups. You can see OH positive on a distribution scale is the commonest, followed by ARH positive blood. So this is the distribution type in US. There's, depending on what your racial and ethnic background is, that data may be slightly different. Now we'll talk about some concept of restrictive blood use, human tolerance, and then critical illness transfusion. One slide that I know a lot of people already know this is the group O is the universal donor, whereas group AB, where they don't have the anti-A and anti-B, is the universal recipient. And then blood is there's some RH factors and some other factors that the lab does, but there is a huge science into finding the right blood unit. So like I said, in an emergency, anyone can receive type O RBCs. People with type O, they're known as universal donors. Individuals can receive AB plasma because it doesn't contain the anti-A or anti-B. And again, this is what determines on what blood group is readily available in the blood bank or the market. Now, there are some concepts of blood transfusion where there's an autologous transfusion. That is the transfusion of a patient's own blood. So if someone's going for a hip or knee surgery a few days back, a few weeks back, they'll have blood stored that can be used at the time of surgery if it's needed. There's donor-directed blood transfusion, in which a family can designate, patient's relative designates the use of the blood during an upcoming procedure. Now, homologous blood transfusion, that's the most common infusion. That's where blood and blood components have been collected from the general public. And then there's a concept of perioperative blood salvage, where reinfusion of the blood lost during and immediately after surgery, there's a collection of that blood lost. Now, what happens in anemia? We all know that it's a physiological reaction. There's an increased production of RBCs, increased cardiac output. There's a shift of the oxyhemoglobin curve to the right. The concept of hemodilution is withdrawing blood and replacing it with crystalloid or colloid solutions to keep the same volume. And this had gained importance in the last 60, 70 years. There's been a number of hemodilution studies, and we'll be talking about a few of the studies, just the salient points, and then you can see the link below. So if you have access to LMS and you're on the PowerPoint, click on this, it'll take you to the actual study. Now, this was one from 1998, published in JAMA. 32 patients, they underwent hemodilution with 5% human albumin to a target hemoglobin of 5. And they found they were able to tolerate that anemia. There was no increase in lactate. There was a mild increase in oxygen consumption. A study in 2000 from the Journal of Anesthesiology talked about EKG changes with severe anemia. And these were 55 healthy volunteers. They were diluted to a hemoglobin of 5. And they found that there was some transient reversible ST segment depression, tachycardia. But overall, the patients were asymptomatic. And again, this is acute hemodilution, which is different from chronic blood loss. There was a study, again, in the Journal of Anesthesia in 1998, published what happens in anemia in patients with coronary artery disease who are scheduled for a CABG. Hemoglobin was reduced from 12.6 to 9.9, so not a big drop, but a 25% drop in their baseline. They found an increase in cardiac index and then oxygen consumption. Now, one of the interesting articles is what happens in anemia, the effect on cognition. And again, published in 2002, they found hemoglobin levels of around 5.7 slowed testing in mathematic questions. And as soon as you administered oxygen therapy, there was a normalization of neurocognitive decline. So again, important to note that the body can tolerate low hemoglobin levels and we don't need to jump the gun, if the hemoglobin is 9 or 10. Critical care patients have, there was a study in 1999 published in NEJM. These were 418 critical care patients. They were randomized into a restrictive approach, which meant transfusion below 7, versus a liberal approach, transfusion below 10. And what they found is the restrictive approach, they did not worsen any clinical outcomes. What is important when we quote studies is meta-analysis. And this was a JAMA 2014 meta-analysis, 17 trials, more than 7,000 patients. And they said restrictive strategy, that is transfusion less than 7, is associated with lower risk of nosocomial infection, so lower risk of pneumonia, wound infections, and sepsis. So very important in the ER setting, in the hospitalist setting, post-operatively, whether it's a hip, knee, or even post-CABG. Now, a lot of societies have come out with these Choosing Wisely campaigns, and the Society of Hospital Medicine, American Society of Hematology, they all talk about hemoglobin levels of 7 to 8 is what should trigger a transfusion. Again, this is all associated with positive documentation. And again, a question comes is, what is positive documentation? Well, any case that requires a transfusion, you need to have a history of melena, hematemesis, bleeding, trauma, severe epistaxis, whatever the history may be, it needs to be a part of your order for writing a blood transfusion order. Now, when someone's requiring blood transfusion, it's expected by auditors that they are monitoring hemoglobin and hematocrit order. So at least twice a day. This is where, this is what you don't want to miss is the sudden drop of hemoglobin. And whether you do it Q8, Q6, Q12, whatever your policy is, depending on what the disease process is, what we're trying to see is what the trend of that hemoglobin hematocrit is. Now, sometimes when patients have bleeding issues, you want to make sure the platelet counts are good. You want to know if their INR is good, or if there's hepatic cirrhosis where coagulant production is less. Hemodynamic instability, so whether your heart rate's greater than 100, or you have hypotension, you have postural instability, syncope, that needs to be part of your documentation for blood transfusion. Mental status changes, whether if someone has had a hemoglobin, they have a thalassemia A or B, and they've always run in the 8 or 9 range, but they are completely asymptomatic, you need to document that. And so don't try and push their hemoglobin up to 9 or 10. With thalassemic patients, there's no way you can even do that. If patients having an acute sickle cell crisis, you need to transfuse blood, but at the same time control the sickling process with pain control, and that just takes time. A lot of it is, it's just there's increased production of those RBCs, so you can be transfusing 10, 12, 14 units over a week or 10-day period. If the acute sickle cell pain crisis still continues, that blood is just, the RBCs are just getting sickled. Now, positive documentation also includes risk and adverse effects. So you need to document if there are any risks, if and what the adverse effect is. So post-transfusion infection, post-transfusion related acute lung injury, febrile non-hemolytic reactions, transfusion-related associated circulatory overload, and sometimes even errors can, so delivering the wrong blood components, or handling of storage errors, or even insufficient transfusion. Now, we are talking about blood transfusion, but as we go forward, there are a number of components of blood products can be transfused, and that's where this insufficient transfusion comes in. Now, what's the cost of blood? So 1 unit of leukocyte-reduced RBC cost about $950. Now, remember, this is not what the acquisition cost of your facility is. This is what it costs in totality. That includes acquisition, includes processing, banking, patient testing, administration, monitoring. Now, I've put this in blue is because the number of blood components transfused unnecessarily had represented about 1/4 of all blood units being transfused. And the range was from 7 to 43, so a huge range, but the average came out to be one out of every 4 unit of blood that was transfused was unnecessary. The reason why this is costly, the reason why this blood transfusion is now being looked at is the 25% error rate in transfusion in terms of medical necessity. So let's look at some economics. So about more than 14.5 million units of blood and RBCs were transfused in the US last year. Now, the mean acquisition cost per unit of RBC is around $210, ranging from $170 to $250. Now, the patient-specific rather than a product-centered application of these modalities is a whole branch of science called patient blood management. And this is where these are being backed up by some huge organizations because they've seen this is a very expensive process and there's a lot of wastage going on in it. Now, CMS introduces the MLN Matters, and I pulled this out from 2005. Clicking on it up on when you're looking at the PowerPoints will take you to this. But this was updated on March 28, 2013. And what they talked about is billing for blood and blood products under the OPPS system. CMS has also released National Coverage Determination Guidelines for blood transfusion, and this is a publication number 110.7 on 100-3 in the manual here. This has been around for many years, has been updated. So when you have access to the LMS, pause on the PowerPoint, click on that link, and it'll take you to this NCD where you can read on the where Medicare benefit categories for blood transfusion occur. Now, there's a concept of fresh blood versus old blood, and fresh blood is that's stored less than 8 days. Old blood has been stored for a mean of 22 days, and blood older than 14 days that's been used in cardiac surgery patients has been associated with worse outcomes, including higher rates of death, prolonged intubation, acute renal failure, sepsis. You'll see a lot of surgeons promoting whether autologous blood transfusion, or if not possible, the fresh blood if it's possible for their post-op bleeding. Now, there's a whole concept of what's tested during blood transfusion, and the reason to put this slide is to educate patients that even though hepatitis B and HIV, and there's a whole bunch of tests that can be done, transmission risk is relatively low. This has advanced many years in the last 15-20 years, where just a few antigens, antibodies were being tested. Even what we're testing right now may just be the tip of the iceberg on what can be transmitted. So again, blood transfusion comes with risks. Now, there's advancing transfusion and cellular therapies worldwide. This was an older name for the Association of Blood Banks, and this is an international non-profit association. It represents individuals, institutions. What they recommend is if a patient has critical care issues, hemoglobin level of 7 should be your threshold for transfusion. Post-operative in patients with coronary artery disease, they talk about 8 or less. And so overall, 7 to 8 is where they're looking at. Now, their entire policy statement is available at this link. So if you click on it, it'll take you there. Now, talking about blood transfusion, the American Red Cross has a lot of data on blood transfusion, and they have reimbursement data, they have clinical guidelines. If you are in the field and you want to see some specific issues, I think this is probably the best site to go to get more information. So recommendations for target hemoglobin level for RBC transfusion. There's some clinical practice guidelines. The JAMA network has a great article on RBC transfusion thresholds and storage. So again, if your providers need some more information, they can go and read this entire article, use some citations, or use the clinical criteria and the evidence-based guidelines in these articles to justify their use of blood. Now, when ICD-10 came in, we all know it required more specificity. And so some ICD-10 information needed for proper coding. And this is where your coders will be asking you, could you add more documentation? Well, we need to know how you're transfusing the blood. Is it a peripheral vein, central vein, peripheral artery, central artery, what the approach is, and what exactly are you transfusing? And so, they have whole blood around to fresh frozen plasma, as plasma cryoprecipitates. One thing that ICD-10 wants to know is this autologous or non-autologous. And this is where, if you have a pre-op patient who's already donated blood, you can put in this is autologous, but many a times this is something providers may not know, and auditors are trying to get more information on this. Your coders may put in a query, may not be to you, maybe going to the blood bank or whatever your source of blood sourcing is, but this is one of the qualifiers for blood transfusion. Now, CMS released A0409, and there's some guidelines on blood transfusion, IV medications. It has to, there's some documentation issues you need to be cognizant of, as well as issues on nursing record on what's needed, as well as who can order the blood. So this is a very good read on defining the scope of practice requirements that must be met regarding the administration of blood transfusion. So what are the factors that affect billing and reimbursement? And I'm going to say, whether it's whatever payer it is, whether it's Medicare, Medicaid, or private, the concept of was blood transfused or not. If the answer is yes, you go down this flow. If the answer is no, the buck stops. You cannot bill for an anticipated blood transfusion. So Medicare is very clear, and a lot of payers are very clear. Whether you've typed and crossed, you've prepared, you may be spending money on monitoring, unless you transfuse that blood unit, and whatever has been transfused is what you'll get paid. And so, once you say yes, transfusion happened, then you need to put in some more specifics on where it happened. The hospital, critical access, outpatient surgery centers, what was the setting of care, inpatient or outpatient? What were the patient-specific lab services provided? Is that included in the unit cost or not that you're asking for? And then what exactly was transfused? So be very careful. Sometimes we've seen cases where there are type and cross orders from the hospitalist. There's a GI bleed, there's an endoscopy, there's some banding. However, blood was never transfused, but it becomes part of the record, saying hemoglobin fell from 9 to 7, type and cross was done. So that cannot be in the patient financial record. You cannot bill for blood that hasn't been transfused. Now, let's talk about some updates from 2017 that CMS introduced. So there's separate payment rates for blood and blood products, and they use this blood-specific cost-to-charge ratio methodology. Now, the good thing is these payment rates are higher by 2.3% than 2016, but the HCPCS code for whole blood transfusion is valued at $115. Now, Medicare is not going to pay for certain codes, so that the granulocyte pheresis unit is not going to be paid. What we did was, pulled out this from the blood bank aabb.org advocacy page, and click on it, you'll get the final rule of the OPPS. But as you can see, whole blood transfusion, that was paid at $221 last year, is now you'll be paid $155, so 30% drop. Blood split products, which aren't used as much, is being the reimbursement had gone up by 29%, but overall there has been a decline in payment. So whether it's plasma-rich units, RBC units, the payments have gone down. And I see Dr. Charda mentioning that I guess it's worth waiting for certain cases before putting in orders for type and cross for blood. And I think that's a good point that you put in. So if someone comes in for as a GI bleed, hemoglobin's 12, 13, it's always good to monitor hemoglobin hematocrit levels, but just saying let's type and cross. Some organizations may feel it's part of their order policy. Some may wait. But again, depending on what the case is, this needs to be decided on a clinical basis. Again, this is just a myth. This is not how this functions. Blood transfusion is a huge management. It's a huge business. There's a huge economy around it. And we as providers who, unless we prescribe for blood transfusion or write the orders, it doesn't go through. So we need to be very careful with it. I know one of our hospitals had texted us on asking how to get the LMS. So simple ways, all of you have links to the LMS login page. If you don't, go onto aerolib.com, scroll down to aerolib LMS, and it'll take you onto this logon page. People who have subscription access already have passcodes to get on. This is how your learners page will look like, and there'll be badges, skill maps, a lot of topics. So if there's, say an acute kidney injury, you want to know what the clinical and regulatory guideline is, and enroll yourself into this course. There's a video, PowerPoint, slides. You start the course and it starts up the video presentation. There's a back-end reporting that happens on what you've done, and you can pull out those badges, share them on your social media profile, or even get certificates that you've completed them. One thing that I encourage all our users to do is get on the Aorta Forums app. It's a free app on your iOS or Android platform. It's called Aorta by Aerolib. Just some really nice discussions happening, more than 100,000 views. So things that you want to know about condition code 44, MLN matters, what administrative law judges. So just a very nice forum to be on. And again, free for anyone who wants it. Topics that we have currently on the LMS is, COPD, sepsis, acute kidney injury, pneumonia, CHF seizures. So pretty much, we talk about all these 11 points. Our focus is disease-specific documentation improvement, and so we reverse engineer the education process by what would you need to know if someone has CHF. What's your documentation issues? Where are the ICD-10 documentation points? What's an auditor going to look at in a CHF patient? And a lot of other topics that are in there. There's some new topics that have been added. Retired ALJ Bob Soltis has been very gracious in allowing us to use some really great webinars on what happens in front of an ALJ hearing. So a lot of updates happening. Some new ones that are coming is the MSDRGs for February. The blood transfusion one will be on by the end of the day today, and you'll have access to it.